Uh, Today's class is on tuberculosis. My name is Bruno Ngala, and together with my colleague John Maore, we'll be presenting on tuberculosis. Our facilitator is Professor Diero. Just a minute, there's a problem with my, okay. So, definition, tuberculosis is a multisystemic disease with myriad presentations and manifestations, and it's the most common cause of infectious disease-related mortality worldwide. Please, could you please switch off your mics? Okay. Pulmonary TB is a contagious, so we have two types of tuberculosis. We have pulmonary and extrapulmonary TB. So pulmonary TB mainly affects the lungs, but may spread to other organs of the body. Extrapulmonary TB is tuberculosis that involves parts of the body other than the lungs. So the main pathogen involved in the pathogenesis of tuberculosis is the Mycobacterium tuberculosis complex, which involves M. tuberculosis, M. africanum, M. bovis, and M. microti, but M. microti is a rodent pathogen. So the most significant here is M. tuberculosis. For the epidemiology, we start with the international stats. More than 1 in 3 individuals is infected with TB. According to the World Health Organization, there were 8.8 million incidences of TB globally in 2010, with 11 million deaths among HIV-negative persons and 0.35 million deaths from HIV-related TB. In 2016, 6.3 million new cases of TB, both forms, were reported to the WHO by its member states, and 95% of cases were reported from developing countries. For Kenya, according to the Kenya Tuberculosis Prevalence Survey of 2016, it was reported that the prevalence was 558 per 100,000 adult population. The highest disease burden was reported among people aged 25 to 34 age group, in males, those living in urban areas, and among the elderly over the age of 65 years. So before we look at the risk factors, maybe we could look at the factors that usually help to determine whether TB infection is likely to be transmitted. So we have the number of organisms expelled, concentration of organisms, length of exposure time to contaminated air, and the immune status of the exposed individual. Infected persons living in crowded or closed environments pose a particular risk to non-infected persons. So the following factors increase an individual's risk of acquiring active TB. Number 1, we have immunosuppression, which under that we have HIV infection, immunosuppressive therapy. We have social factors such as intravenous IV drug abuse, alcoholism, smoking, and low body weight. Diseases such as diabetes mellitus, silicosis, and end-stage renal disease. Then we also have malignancies like hematologic malignancies, drugs such as tumor necrosis factor alpha and antagonists. The age, for age, we have those below 5 years who are more predisposed to TB. Then we have intestinal bypass surgery and also chronic malabsorption syndromes. So tuberculosis is transmitted through the air, and the transmission occurs when a person inhales droplet nuclei containing Mycobacterium tuberculosis. And the droplet nuclei traverses the mouth or nasal passages, upper respiratory tract, and bronchi to reach the alveoli of the lungs. So the pathogenesis and the pathophysiology of pulmonary TB. So infection with Mycobacterium tuberculosis is the most common cause of infection, and it mostly affects the lungs through exposure to infected aerosols. So it's important to know that a person with active pulmonary TB in a single cough usually generates 3,000 infective droplets, with as few as 10 bacilli needed for infection. Organisms usually remain in the air for up to 6 hours. So anyone walking in that same airspace as the person who coughed may become infected. So inhalation leads to one of the following outcomes. Number one, you have immediate clearance, chronic or latent infection, suppressed into latent TB infection, which is inactive, rapidly progressive disease, reactivation of disease. So the risk of developing disease after being infected depends largely on endogenous factors, such as the individual's innate immunologic and non-immunologic defenses, and the level at which the individual's cell-mediated immunity is functioning. Clinical illness directly following infection is classified as primary TB and is common among children in the first few years of life, together with the elderly and among immunocompromised people. So although primary TB may be severe and disseminated, it is not associated with high level transmissibility. When infection is acquired later in life, the chance is greater that the mature immune system will contain it, at least temporarily. So bacilli, however, may persist for years before reactivating to produce secondary TB, which, because of the frequent cavitation, is more often infectious than is primary disease. A person with the disease usually generates droplet nuclei that contains tubercle bacilli. So the droplet nuclei are inhaled by the potential host into the lower lobes, of which a majority are normally trapped in the upper airways and get expelled before they reach the alveolus by the ciliated mucosal cells. So once inhaled, the organisms lodge in the alveoli and initiate the recruitment of macrophages and lymphocytes. Macrophages undergo transformation into epithelial. Yes. Okay. Once inhaled, the organisms lodge in the alveoli and initiate the recruitment of macrophages and lymphocytes. So macrophages undergo transformation into epithelial and Langerhans cells, which aggregate with the lymphocytes to form the classical tuberculous granuloma. So in this diagram, we have, this is just a microscopic picture of tuberculous granuloma. And so usually the normal lung tissue is lost and replaced by a mass of fibrous tissue with granulomatous inflammation, characterized by the presence of large numbers of macrophages and multinucleate giant cells, as the ones that are pointed by the small arrow. Then there's a central area of this focus of granulomatous inflammation, which shows caseous degeneration, which is shown by the large arrow, pointed by the large arrow. So numerous granuloma aggregate to form a primary lesion, also called a Ghon focus, which is a pale yellow caseous nodule, usually a few millimeters to 1 to 2 centimeters in diameter, which is characteristically situated in the periphery of the lung. The spread of organisms to the hilar lymph nodes is followed by a similar pathological reaction. The combination of a primary lesion and regional lymph nodes is referred to as the primary complex of Ranke. So reparative processes usually try to encase the primary complex in a fibrous capsule to limit the spread of the bacilli, which now leading to what we call latent TB. So if no further complications ensue, this lesion usually calcifies and is clearly seen on a chest X-ray. However, lymphatic or hematogenous spread may occur before immunity is established. Seeding secondary foci in other organs, including lymph nodes, serous membranes, meninges, bones, liver, kidneys, and lungs, which may lie dormant for years. So the only clue that infection has occurred may be the appearance of a cell-mediated delayed type hypersensitivity reaction to tuberculin, demonstrated by the tuberculin skin testing. So if these processes fail, primary progressive disease usually occurs. The pathophysiology of lymphatic TB. So we're now looking at the extrapulmonary TB, the types and presentations of extrapulmonary TB. So the first is lymphatic TB. Cervical adenitis is usually caused by lymphatic spread from the mediastinal lymph nodes after reactivation of a primary lung infection. However, tuberculous lymphadenitis can be the initial manifestation of primary infection from non-tuberculous mycobacteria. The presence of necrotic lymph nodes usually increases the probability of tuberculous infection at other extrapulmonary sites. So mainly, the main way through which the bacilli reach the lymph nodes is by hematogenous spread, and they usually lodge in the sinuses where they are phagocytosed by inactive macrophages. The ingested bacilli replicate in the macrophages until proteolytic enzymes and cytokines from other macrophages cause cell death, and the bacilli are released. So monocytes and activated macrophages form a granuloma to stop the infection and limit the replication of the bacilli. At this stage, usually the granuloma transforms into a lesion with a necrotic center and peripheral granulation tissue. Next, we have central nervous system TB. So the hallmark feature of tuberculous meningitis is the formation of thick gelatinous exudates. So these exudates are usually copious in the basal regions of the brain. Other characteristic pathologic changes are meningeal inflammation, vasculitis of the arteries of the circle of Willis while traversing the basilar exudates, and obstruction of the CSF fluid resulting in hydrocephalus. Multiple small intracranial and spinal tuberculoma are frequent when TB meningitis is a part of the miliary tuberculosis. So when the thick inflammatory exudates of TBM surround the spinal cord, complications include tuberculous radiculomyelitis, spinal tuberculoma, myelitis, syringomyelia, vertebral tuberculosis, and very rarely spinal tuberculous abscess. Tuberculous arachnoiditis leading to myeloradiculopathy is the most characteristic spinal complication of TBM. Maybe to just define myeloradiculopathy, it's usually the dysfunction of the cervical spinal cord and the nerve root, which it's caused by compression of the spinal cord and the nerve root. Next, we have genitourinary TB. So the bacilli usually reach the kidneys through hematogenous spread, and the high perfusion rate and oxygen tension in the kidneys usually creates a favorable environment for the bacilli. So the bacilli lodge in the periglomerular capillaries where they form granulomas that remain silent for many years. During disease reactivation, secondary to a breakdown in immunity, the granulomas enlarge and coalesce. So the bacilli are able to enter the glomerular system and become trapped in the loop of Henle, establishing a new foci of infection in the renal pyramid. So granulomas in the papillae become necrotic, forming ulcerocavernous lesions in the pelvic-calyceal system. So usually chronic inflammation results in cortical destruction and stenosis of the collecting system. Those are the forms of the extrapulmonary TB that I could get. And for more information on the also rare forms of extrapulmonary TB, I'd advise you to get to this link and get more information on it. So I welcome the next presenter.
So good afternoon. Is my screen visible? Sure.
Yes, your screen is visible very well.
Thank you, Prof. So I'll take you through the management of tuberculosis. So in terms of presentation, so TB occurs in two clinical forms, as my colleague has alluded. So we have a pulmonary and extrapulmonary TB. So pulmonary TB composed most of the bulk, the commonest one, which is 80% of the cases. So in terms of presentation, history, you have to ask of present with cough, which might be more than 2 weeks, might be productive in nature with sputum, blood stained, or even hemoptysis. So it might be also be accompanied by chest pains and constitutional symptoms like fever, weight loss, night sweats. And also you have to also probe the history of a contact with any person having TB, dyspnea and respiratory distress, fatigue. You also realize that elderly and immunocompromised patients may also have are easily to have these comorbidities. Having that comorbidity of they can easily be predisposed to TB. So you also have to ask about HIV status, DM history, CKD history, corticosteroid therapy, TNF, alpha inhibitory therapy, smoking. So for smoking, you realize that actually for smoking, the smoke itself actually impairs the ciliary and also the alveolar macrophage functioning. For DM, diabetics actually, there's a way it interferes with the immunological components like macrophages. You also have to ask about the alcohol history. For the alcohol history, for those who consume alcohol, alcohol impairs also cell-mediated immunity and also the TNF secretion. You also need to elicit a history of malnutrition, intravenous drug misuse, and etc. In terms of physical exam, so remember this is a chronic condition. So most patients might present with wasting, maybe due to their nutritional deficiency. Also, they can also, with the systemic effects of the chronic condition, they can also have issues with malabsorption syndrome, also failure of utilization of components like iron. Also, they can have bone marrow suppression, as we will see in terms of the systemic effects of the TB as well. So you need to check your vitals. They present with fevers and tachypnea. Respiratory exam, increased vacorimeters, reduced chest movement. So in terms of presentation of respiratory exam, they can either present with an up one or a down one presentation, depending on, for example, if it's a TB accompanied by pleural effusion, so you'll expect the changes in terms of the respiratory exam. So it's not like casted only, like they'll have to present with increased vocal parameters or reduced chest movements. So you can also elicit other, depending on the manifestation of the TB itself. So for the bronchial breath sounds, also you check on crepitations, vocal resonance, on auscultation. They can also have bronchi due to partial bronchi obstruction. They can also present with pallor and finger clubbing. In terms of investigation, so GeneXpert is it's not the preferred, it's not a gold standard, but it's more preferred because of its timing. It takes short time, actually within within below two hours. Actually, you can have the results in terms of it, and also it also helps to access the resistance of rifampicin. So this uses nuclear acidic amplification technique. It also has high specificity and sensitivity. So the samples that you can use for GeneXpert are sputum, CSF, gastric aspirate, nasopharyngeal aspirate, pleural, precardial, or acetic fluid. The leader, remember, I said in terms of presentation, you can present with a myriad of picture of presentation. Sputum is one of the most sensitive sample for GeneXpert. Although use of stool, sputum, and urine samples, it's still under investigation. I'm not sure of it in terms of the GeneXpert. So a sample with also blood in it may bring invalid. So when you're collecting, be it a CCF, you remember that if you collect a CCF that is contaminated, that has maybe like blood, it will interfere with your invalidity of the results that you expect. So I think I explained why you use the GeneXpert because of rifampicin resistance and in all, and also it's quickly accessible test for the TB. The other test you can use is sputum for microscopy. So you use a ZN stain for acid fast. So its sensitivity compared to the GeneXpert is about 40 to 60%. It's used for diagnosis and also for follow-up of the treatment. So all patients suspected to have PTB, you should take two samples of, you should collect two samples of sputum for acid fast. So one is the time of the collection is on the spot one, and the other one, The second sample, you can collect it in the early morning collection the following day. I think the reason is because of the concentration of that sputum. Maybe that's the reason why maybe they take a early sputum morning. I'm not sure, maybe Prof will clarify, but I think that's would be the reason. It's also used to follow up in all bacteriological confirmed TB. So remember, at the end of the 2 months, so you can also access TB in terms of the bacteriology or also clinically. You can also assess TB clinically by use of imaging. So in case maybe your clinical assessment has a high probability of a TB, you can continue your treatment as you wait to do your sputum for microscopy, which should take place after within 2 months. So within 2 months, you should expect a sputum for conversion of, if it was negative at the start of the onset of management, at the end of the 2 months, it should at least have tested positive. Also, the sputum is also used to follow up on the diagnosis of on your treatment management if there is any treatment failure by 5 months, and also after the end of your cure for the management of the treatment, you should also use the sputum to confirm your management. For the culture, as I said, it's a gold standard for TB, though it's not routinely used for diagnosis in most centers. So for indications where you need your culture is where there is a failure for the first line treatment. We'll check those treatments options that we'll have as we go on with the slides. So also the lack of the smear conversion at the end of the 2 months on the first line treatment. So these are some of the indications that why you use a culture. Also a patient who returns to your clinic after maybe a default of your treatment. And also symptomatic contacts of drug-resistant TB, also healthcare workers and those patients who present with relapse. So some of the culture techniques we are aware of, I'm sure everyone is familiar with Lowenstein-Jensen medium, as we usually see them in the lab and usually use them for culture and sensitivity. So it takes 6 to 8 weeks. So the others that are available, we have BACTEC system, which growth can take 5 to 10 days. MGIT, mycobacterial growth indicator tube, which can take 7 to 12 days, and mid-loop Brook media. So in terms of imaging, as I said, sometimes if you have high suspicion of a TB, but the sputum is negative, you can continue empirically with the management using chest radiograph. So for patients who have who usually suggestive of TB, PTB, the upper zone of lung shows can show patchy shadows. So this can be an evidence of cavitations and also scarring. So remember, as my colleague has did in terms of pathogenesis, so you can have a healing process through cavitations or even scarring or fibrosis, especially for the latent cases of the TB. So in HIV infected persons, the radiographic picture is more often atypical with the lower or mid-zone shadows and the presence of a HeLa or a mediastinal lymph node involvement. Then it can also have a picture of a miliary picture with miliary molting, pleural or pericardial effusion. So these mostly are for the immunocompromised people. So this point, the next point is whereby I think I explained this one. All patients with features of an X-ray suggestive of TB, you should have sputum specimen submitted for microbiology examination as a gene expert. So it's a major omission to diagnose TB on the basis of a chest X-ray only. So the other image you can do is you can also do a chest CT scan. So these are some of the images showing some of those things that we've evaluated. So we can check the first one and also the second on the upper lobes. You can see some opacities, some of the consolidations, maybe the occultation. So the next one kind of shows a miliary picture of consolidations, I think in both of the infiltrates in both of the lung tissues. So the third one explains the same of infiltrate on those lung tissues. Other tests that you can do LAM, which is a lipoarabinomannan. So this is an antigen that is found on the cell wall of a Mycobacterium bacteria. So mostly this one is done for, especially for those patients who are immunosuppressed or shows the symptoms of immunosuppression. So they should not be used as an alternative test to gene expert, but can be performed to help in diagnosing TB while waiting for gene expert test results. So, but one of the disadvantages of it is compared to gene experts, you cannot be able to detect resistance to rifampicin, that antibiotic that is used in the management of TB. So the other test you can do fluorescence light emitting diode microscopy. So this one it uses image to show the small specimen of the microbes, that is mycobacteria. I'm not sure if it's commonly done here. So line probe assays you can use for drug sensitivity tests for both the first and second line TB drugs. So other supportive tests you can do for CBC, your baseline will show leukocytosis, and also you have to rule out other acute differential causes, or as we will see, the differential diagnosis of the TB. So ESR and CRP, remember, it's the markers of inflammation. UECs, you need to check your renal function assessment, plus electrolyte levels. Lung biopsy specimen, so you can obtain through fiber optic bronchoscopy, open lung biopsy, or transthoracic route. But there is something actually, an article I found on UEC. They were saying that most of these patients present with a picture of hyponatremia, especially those who have maybe Prof will clarify, especially those who have most of it. They were actually considered of more of pulmonary disorders, and TB being one of the disorders. It's an American review article that was published by 2 people. So in their research, they were actually checking on a syndrome of inappropriate ADH secretion, and they were suggesting that with more of pulmonary disorders, being that they cause hypoxemia, and hypercapnia, they can show an elevated level of they have a picture of elevated level of vasopressin levels, so which can stimulate a mechanism of that syndrome of inappropriate ADH. So giving a picture of hyponatremia. So I'm not sure if it's one of things that we can consider also in terms of UEC, that's the hyponatremia picture. Maybe Prof will clarify that. The differential diagnosis of the TB, you have a chronic lung disease, the COPD, intestinal disease, bronchiectasis, lung abscess, lung cancer, sarcoidosis, and typical pneumonias caused by the fungal pneumocystic jirovecii, mycoplasma, or chlamydia bacteria, the typical ones. So the TB treatment, so your aim of treatment is to cure patients, and therefore you prevent suffering, death from the TB. Your second aim is to prevent long-term complication or the sequel of the TB. You also want to prevent relapse of the disease. You want to prevent transmission, and you want to prevent the development of drug-resistant TB, which is one of the key that we'll manage actually in terms of our management here. So some of the basic treatments of TB, so they say that you never use one drug, so you always use a combined fixed dose combination. So this is whereby it involves use of multiple drugs where you take in combination. It is done actually to prevent emergency of drug resistance to any of the drugs, as we will see their resistance. So it contains 2 or more medication within the same. So one tablet can have 2 or more of a combination of the medication in terms of a cap in capsule, or is also in tablet form. So the other principle is the dosage of the drug is based on the weight, and you should also take care of intake should also be directly observed, as some of the patients might prefer to take if it doesn't have FDCs. Some patients might prefer to take some tablets and leave others. So you should ensure that the entire treatment is 6 to 8 months treatment should be taken to prevent the issues of resistance and complications, as we see. So these are some of the anti-TB drugs that are used. So for the first line, you have the normal one, RHZDE. And then the second line, it's mostly of aminoglycosides. The third line is quinolones. Then you have other groups, the fourth group and the fifth group. So take note of the other group, because in terms of the management of multi-drug resistant TB, so there's a more of a combination of the other lines of drugs. So it's good at least you familiarize yourself with this table, as it will guide us in the management of multi-drug resistant TBs. So the treatment regime for, as I said, the intensive phase, the normal one use 2 months of RHZDE. So it's called the intensive phase, where the target is to reduce the load of the bacilla. You also have the continuation phase, where you do for 4 months RH or RHE if you have suspected or known areas with the isoniazid resistance. So treatment is offered through weekly drug collection during the intensive phase and 2 weekly during the continuation phase. I think I explained this slide of the fixed drug combination. Maybe what I didn't mention there is the reason why the disadvantage of fixed drug combinations, whereby they reduce the bioavailability of some of the drugs, particularly if you have a combined tablet, so it reduces the availability of some drugs, particularly the rifampicin, and then flexibility in obtaining an optimal dose of some agents such as pyrazinamide may be lost. So these are some of the formulation according to the weight. Remember, we said that the dosage is based on the weight. So I think we will check on these later. So if you have less than 30 kgs, 30 to 37, 38 to 55 kg and above 55 kg. So these are combination of those regimens of the treatment. So how do you monitor the patient while he's on those anti-TBs? So remember, we said that the sputum smear at 2 months, you need to confirm your diagnosis, and also you are at 5 months, you need to confirm your treatment failure. At 6 months, you want to confirm your cure. So you check their weights. At least with increase in weight, it shows a positive response to drugs. You need to assess your nutrition also, and also assess the patient's hemoglobin, as it has a tuberculosis actually can cause anemia. So some of the toxicity to look for are isoniazid. Isoniazid, as we know, it has a peripheral neuropathy, so you have to add pyroxenamide for the prophylaxis for peripheral neuropathy when you are giving isoniazid. Rifampicin causes oral discoloration of body secretion, so any mucus secretion, including urine, from the eyes, from the vomiters, hepatitis. It can also cause hepatitis and thrombocytopenia and pruritus. So it's a strong enzyme inducer. As we will see actually, when someone who has HIV, how you need to combine due to the drug interaction. So we will see that in the next slide. But take note, it's a strong enzyme inducer. Pyrazinamide, it causes hepatotoxicity. The common one is hepatotoxic effects. Ethambutol, it's optic neuritis, and decreased red color discrimination, red-green color discrimination, sorry. Streptomycin, it causes ototoxicity and nephrotoxicity. So, so how do you do when a patient presents with hepatotoxicity when he or she is on anti-TB drugs? So the common, remember the common drug that causes hepatotoxicity, we talked of pyrazinamide. So you need first to stop the meds, and you do your LFTs. As you stop the meds, you wait for 2 weeks, then you assess your liver enzymes again. And if they go back to normal, you don't need to go to the same regimen that you were in. So put the patient on the same meds, but replace a pyrazinamide with streptomycin, or you can give RHE alone and prolong the treatment. So you remove pyrazinamide, but you prolong the treatment up to 12 months. So if after 2 weeks your LFT don't go back to normal, you do a holding regimen, which is a composition of streptomycin, isoniazid, ethambutol, and quinolone. I'm not sure if this is a practice now, but I'm not, or if there is any alternative that is available for hepatotoxicity. Maybe Prof will also maybe clarify on the same. So if you have a treatment, if a patient who have a relapse or a failure or returned after default from initial treatment, so these I think is more of what I've explained before. So a smear which turns positive after 6 months, which means you have a treatment failure. So you do your gene expert. If rifampicin is sensitive, you retreat with the normal regimen. So it means if you are if you do your gene expert and you don't see any resistance to rifampicin, so you do your you go back to the normal regimen. But if rifampicin resistant, you treat it as a multi-drug TB resistant. So we'll see with the short regimen management that is used when you have a rifampicin resistant or a multi-drug resistant TB. So then you submit your sputum submitter. You also do your culture and the drug sensitivity test. So what happens when a patient both TB and a patient with TB and HIV? So there is an algorithm which is called the intensified case finding. So this algorithm it was brought in as a tool to guide you in the management of some patients who live who are HIV positive, and but so it's a TB screening and prevention services. So you should do TB screening and prevention service to all patients living with HIV at every clinic visit and to all household contacts of active TB. So the World Health recommends that all patients living with HIV should be screened with a clinical algorithm. I think I'll post it later I'll share it later with the groups. So it's a clinical algorithm at every clinical encounter. So those who do not report of any, so that algorithm has a cough, a fever, weight loss, or night sweats. And so if they don't report with any of these symptoms, they're unlikely to have an active TB. They should be offered a prophylaxis, which we'll see in the next slides, which is Isoniazid preventive prophylactic therapy. So in case they lie into this group of ICF, but they don't show an active symptoms or an active TB, you should have a prophylaxis for them. So we will see the prophylaxis as in the next slides. I will post it in the next slide. So but the TB, so in children using protease inhibitors, so in children who are on HIV management, so they might be on amacavir, lamivudine, and lopinavir. You should, due to the remember I mentioned of rifampicin being an enzyme inducer. So in terms of the interaction with the lopinavir, so they can reduce the pharmacoactivity of the lopinavir. So in this case, you have to super boost the lopinavir with ritonavir. So you have to add ritonavir in their management of their HIV. Or you can also, if you can also do away with the lopinavir and use the efavirenz based regimens, which are so these are NNRTIs. So you can opt to use abacavir, lamivudine, and efavirenz, or you can use tenofovir, lamivudine, and efavirenz. So this one is where you do away with the lopinavir due to their rifampicin interaction. So you continue same regimen for duration of TB. For the TB, you continue the same duration, and then you consider for a regimen optimization after completing the TB. So if you have to change your regimen of the HIV drugs when a person is on HIV management, or sorry, on HIV, yes, with HIV management, after maybe the completion of your TB treatment, you can opt to go back to your normal regimen of the HIV management for optimal management of the long life condition. So you can also give dolutegravir on all based. So dolutegravir is one of the newest second generation integrase, which is more of has a lot of safety measures, but you should also be careful if a patient is using drugs that have a metal component in it, like lithium for management of antipsychotic, or maybe aluminum hydroxide for the management of GI symptoms. So it interacts actually with the metal component consisting drugs. You can also give a TDF, 3TC, DTG, plus the DTG 50 milligrams. So this one is given in the morning and also DTG in the evening for a duration of the rifampicin, where you are giving rifampicin for the management of the TB. So patients who are not yet on so if you have a case of a patient who presents he or she has not started the management of the HIV regimen and presents with TB, so you initiate you should initiate your HIV therapy as after 2 weeks due to the iris, immune reconstitution inflammatory syndrome. But for the TB meningitis, you consider delaying your starting of the heart for up to 8 weeks. And then what happens to patients who are already on the management of HIV regimen? So for this one, you start they say you start TB treatment immediately, and I'm not really sure, but from the source I was getting, they say you can still give both the management of both the drugs for the HIV and also for the TB management, but you also monitor closely for the iris and also maybe for the drug and drug interaction. I'm not sure if in case they develop iris, what you need to do, whether you need to withdraw your heart, all of them, or you need to check for only one drug. Maybe also Prof maybe will clarify on that note. So you should also be aware of the risk of the renal toxicity when a patient is on the TDF and the aminoglycosides, which are the second line of the anti-TB drug management. So remember I talked over ICF, the intensive care findings. So, and I said that if a patient doesn't present with those clinical and an active TB, you should do Isoniazid preventive therapy. So all patients living with HIV above 12 months of age, children and adults, or who screen negative for TB. So these are the class of people you should start on the IPT. And all children under 5 years old, irrespective of their HIV status, who have had a recent close contact with a person with sputum positive TB disease, but with no evidence of an active TB. And also neonates born to mothers with TB or exposed to close contacts with TB should be given this therapy. And also prisoners who screen negative for active TB. So remember, in prison there is a lot of overcrowding, and those risk factors are almost more motivated there, irrespective of their HIV status. So there are some of contradiction to isoniazid preventive or prophylactic therapy. So if someone has an active TB disease, so you need to manage it as a tuberculosis disease. So you don't need to give IPT. And if a person has an active hepatitis or active substance use and or regular or chronic alcohol, heavy alcohol consumption, and if has symptoms of peripheral neuropathy, poor adherence, patient who currently have detectable VL after at least 6 months on ART should not also be initiated on this. So poor understanding also of IPT by parent or caregiver, and previously completed a full dose of a course of IPT and exposure to multi-drug resistance or extreme drug resistance TB. So these are the contraindications to isoniazid preventive therapy. You suspect treatment failure based on the clinical microscopy and imaging. So in clinically, if the patient is being managed, but the symptoms are worsening or like characterized by maybe there is still weight loss and the respiratory symptoms are still not improving or at least showing signs of improvement, And also microscopy, the patient after maybe like 6 months of your management, the smear still turns positive. Also imaging, where there is a progressive, extensive, and bilateral lung imaging confirmed on X-ray for patients with no option of for surgery. So remember, I talked of a drug-resistant TB. So the drug-resistant TB can either be monoresistant, or a polydrug resistant. So for the monotherapy is whereby you are only resistant to one first-line anti-drug TBs, either isoniazid, rifampicin, pyrazinamide, or streptomycin. So for polydrug resistance, you can have multi-drug resistant. You can also have extreme drug resistance and extensively drug resistant TB. So for multi-drug resistant, remember I said that is whereby you have you are resistant to at least isoniazid and rifampicin. So both of them with or without any other regimens of the drugs. Then you have extreme drug resistant TB. So it's defined as so you have isoniazid and rifampicin, which is associated with resistance to either second line or a third line in injectables, but not both actually. And then extensive drug resistant is whereby you're resistant to isoniazid, rifampicin. So you are resistant to first line, second line, third line, and maybe even and fourth line actually. Then for the totally drug resistant is whereby you are resistant to all lines of drugs that actually have locally been tested as a medication for the same. So you can also have primary drug resistance. So this occurs in a patient who has never received anti-TB therapy. I don't know the reason why, maybe. But secondary resistance is whereby maybe you develop resistance during or following chemotherapy in patients who have previously had a drug-resistant TB. For drug-resistant TB diagnosis, you do culture and your sensitivity. We've talked more actually on the same line. You can also do a rapid test, multi-drug TB resistant. Is a molecular probe that detects resistant mutation in 3 TB genes. So how do you treat the multi-drug TB resistant? So here, they use a combination of 7 drugs. Remember that table that I talked about. So although there are also the newer drugs like benaquilline and laminine, but this is a short regimen of TB drugs, which has 7 drugs. So you can have, so you manage it in 4 to 6 months, depending on your culture and microscopy, and also another intensive phase and a continuous phase. So intensive phase you do for 4 months, but you can extend it to 6 months if your smears or your culture turn positive at the end of the 4th month. You can still continue for an addition of another 2 months. But if they are negative, you can go to the continuation phase now. So for the initiation phase, you have a kanamycin, mexofloxacin, prothionamide, and pyrazinamide. For the continuation phase, you have you add another two new drugs. So the only added drugs there is clofazamine, which remember we said is on the 5th group, and then you add andhabito. So pyrazinamide, moxifloxacin, you continue them in your intensive phase. If drug sensitivity test shows resistance to any of this short-term regimen drug, so you stop your regimen, this short-term regimen, and maybe now you manage the patient, you individualize your treatment on the patient. So remember I talked of extensive DTB. So it's whereby you individualize the regimen based on a drug sensitivity culture and patient drug history. So you should use at least an injectable, preferably high generation quinolone, cycloserine, prothionamide, pyrazinamide, and add at least 2 drugs from group 5, which we discussed on. So the injectable should be given at least 12 months. So for every positive culture after 3 months of treatment, you add 3 months of injectable after the 12th month of your management. So if the patient becomes culture positive after a period of negative cultures, repeat the culture and the drug sensitivity test. If the culture is still positive, you counter the first culture. You count the first culture positive as the first month of treatment, and start your treatment. So the prevention of TB, how do we prevent TB? So you need to do your household ventilation. So it should at least be ventilated well, avoid overcrowding, and at least it should have a good ventilation. You also do contact tracing. You also do your nutrition well, case detection and treatment using the dots that we talked about. You also do can also do a BCG vaccination. So it prevents establishment of infection and the development of severe disease. So with actually the era of the COVID, there was actually a highlight on our news a week ago. They were talking about nowadays there's more of a follow-up on COVID. So we've forgotten too much emphasis on our TB. So there's a lot of a relapse actually of TB management, because most cases now are being masked by the TB. So you need to take caution of that. So my colleague discussed extrapulmonary TB. So you realize that TB actually affects all. It's a systemic, actually, it has systemic manifestations, just like the COVID. I think it's only the nail and the teeth that are not actually involved in the for the TB. So it affects all organs except hairs and the nails, as I said. So so these are the extrapulmonary TB. You have the TB GUT. You have meninges that affects the CNS. You have pericardium, pleural, bones. So these are some of the ones that I think I'll discuss on the management of the extrapulmonary TB. So the TB lymphadenitis is the most common form of extrapulmonary TB in both HIV and non-HIV patients. So it presents with a painless swelling of the lymph nodes. So they are usually discrete in early disease, but can become matted over time and may result in fistula tract. So it's associated with less than 50% is associated with pulmonary TB. Is associated with pulmonary TB. So for diagnosis, you do your gene expert FNA, or a surgical excision, or incision, or biopsy. So for the biopsy, you'll I think most of them are described by my colleague. You'd see a granulomatous lesion with or without visible acid-fast bacteria. Cultures are positive, and in 70 to 80% of the cases. So for the treatment, you do 2 months of RHZE and 4 months of RH. So for the surgery, for establishing the diagnosis, and also when you have advanced local disease, persistent disease, or a fistula that is draining. So this is an example of a TB of the lymphatic. So for pleural TB, it accounts for about 20% of extrapulmonary TB. So the symptoms are cough is almost always present, and the shortness of breath. The degree depends on the amount of effusion, fever, and pleuritic, can also have pleuritic chest pain. So an examination, they have dullness to percussion and the absence of breath sounds. So for diagnosis, you do a chest X-ray or thoracentesis, whereby the color of the fluid is straw colored or hemorrhagic. It's exudative with protein concentration of more than 50% compared to the serum. They have white blood cells, and so you also do your gene expert. Cultures are positive. You also remember of the test that Prof talked in the morning, of adenosine deaminase test. So for tuberculosis emphysema, it usually results from a rupture of a cavity with a spillage of a large number of organisms to the pleural space. So you have an enclosed cavity. So depending, it can rupture and it will spill those microorganisms. So you can end up with a pleural emphysema. So it may create a pleural fistula with air in the pleural space. So management of both the tuberculosis emphysema and pleural effusion. So you do 2 months of RHZE plus 4 months of RH. You can also do therapeutic synthesis or chest tube drainage. So this is a picture of a pleural TB. So you can see more of a effusive picture. Yeah. So skeletal TB, it is responsible for 10% of extrapulmonary cases, and it's common in weight-bearing joints, the spine, the hip, and the knees. So it's called the TB spine, or if it affects the spine, it's called the TB spine or Pott's disease, and it involves 2 or more adjacent vertebral bodies. So in children, the more is in upper thoracic, and in adults, it's lower thoracic and upper lumbar in adults. So it's also with advanced disease, it leads to collapse of vertebral bodies, resulting to in kyphosis, and also it can also lead actually to paralysis actually, and also give us have deformity. Diagnosis, you can do your spine X-ray, MRI, or CT. So you can confirm through aspiration of the abscess or a bone biopsy. For microscopy, you will see those cacheating necrosis, and for culture, it's 50 to 80% positive in most cases. Treatment, so for the TB spine, you see it's a different one. For the TB spine and the meningitis and the TB bone, they do 2 months of RHZE plus 10 months of RH. You also give corticosteroids, especially for the TB spine and also TB meningitis and the bone. But I've seen actually with the current usage of corticosteroid in TB of pulmonary, I'm not sure, but I've seen more of pulmonary disorders being corticosteroid actually being one of therapeutic agents used. Maybe Prof, maybe you'll also clarify on the same. So you can also do surgical decompression, corticosteroid dexamethasone in cord compression. These are radiographic investigation of an X-ray of the spine. So we can appreciate the reduced disc spaces and also the destruction of bodies of the vertebral bodies, and also the loss of trabecular pattern. So I think we'll see it in our readings. For the TB meningitis, so patients present with a subacute febrile illness. So it has 3 stages. You have prodromal phase, which is more of an unspecific kind of a picture with no definitive neurological symptoms. So you can present with malaise, headache, low-grade fever, and personality change. So for the stage 2, we have a meningitic phase with slight or no clouding of with clouding or with no clouding of sensorium, and so this is it's characterized by the inability to think clearly or concentrate. So that is a clouding of sensorium, and a minor cranial nerve palsy or no any neurological deficit. So stage 3, it's a paralytic phase. So there is severity of your inability to think clearly. You can also have convulsions, focal neurological deficit, and involuntary movements deficits. So atypical presentations can be an acute, rapidly progressive meningitic syndrome suggesting pyogenic meningitis, or it can also have a slow progression, dementia over months or even years with personality changes, social withdrawal, loss of libido, and memory deficit. So it's actually, I think it's more not easily picked easily. So on presentation, you can have tuberculoma, which presents as one or more space-occupying lesion and usually causes seizures and and the focal signs. So I think it's on a chest on CT, sorry. So you can have enhanced that tuberculoma and enhanced ring lesions. So remember of all the other organisms that also present with enhanced ring lesions. So you need to do your labs well, and also as you clinically tie with your CT or MRI. So biopsy is necessary to establish diagnosis. Remember, you can also have other enhancing ring lesions, picture of conditions. For investigations, you do your CSF analysis. So CSF analysis, so your pressure when it can be either higher than normal, sorry. And then in your appearance for the CCF, remember we said that when you're collecting your CCF, you should at least make sure that it is not blood contaminated. So you should be clear or slightly turbid. If the CSF is left to stand, so a fine clot resembling a cobweb may form due to the very high level of protein in the CCF. So hemorrhagic CCF may be present. So this you can attribute to fibrinoid degeneration of vessels resulting in hemorrhage. So your CCF analysis also you'll have a low glucose and also pleocytosis. You can also send it your CCF for the gene expert. For your culture, CSF culture, you do culture for the Mycobacteria tuberculosis, MTB. So anti-TBs, remember I said you do it for 2 months of intensive phase and 10 months of maintenance with RH. So and also remember I said you can also add the corticosteroid therapy, which is dexamethasone or prednisone taper. And you should not stop actually your corticosteroid. You should taper them before you shouldn't withdraw your corticosteroid immediately. The last one I think of the slides is the TB of the upper ear. So remember, you said TB can affect any organs. So it involves. So remember where your upper airway starts. You can have larynx, pharynx, epiglottitis involvement. So the symptoms can have a presentation of hoarseness of voice, dysphonia, dysphagia, in addition to a chronic productive cough, ulceration also on laryngoscopy. Gene experts to return positive. Your biopsy may be necessary in some cases to establish the diagnosis. So genitourinary TB, I think my colleague talked more on it. So the common presentation, you have urinary frequency. So urinary symptoms, basically, in terms of frequency, dysuria, nocturia, hematuria, and abdominal or a flank pains. So urinalysis you can have by urea and hematuria. So you culture the morning urine specimen. You can also do intravenous or pylorography or abdominal CT or MRI. So it will show deformities, obstructions, calcification, and also ureteral strictures. Genital TB, it's more common in female than in male patients. So it affects fallopian tubes in females and the endometrium. And it can also may cause infertility, pelvic pain, and menstrual abnormality. So for the male, you can have those symptoms of otitis, prostatitis, sorry, and epididymitis. Diagnosis is culture and biopsy on culture, sorry. So for the TB, pericarditis, or TB of the heart, it's increasingly becoming common in most of our HIV patients. So they present with shortness of breath, which is the most common symptom. And also other associated symptoms, tachycardia, tachypnea, edema, congested neck veins, distal heart sounds, rub, some of other common signs. So chest X-ray, you'll see a large heart, globular heart. So echo, you can confirm your diagnosis, and then you can also do pericardiocentesis for diagnostic, and it will also play a part in therapeutic management of the patient. Constrictive pericarditis is an uncommon complication. So for the treatment, you do 6 months, 2 months of RHZE and 4 months of RH. Also, you can also add a corticosteroid therapy on the same. these shows you can see a globular heart, actually even more compressing or masking even the air with the lungs, the tissue. So typical pericarditis. So I think GITB, it makes up of 3.5% of extrapulmonary cases. So the terminal ileum and the cecum are the commonly sites. So you can present with those GI symptoms, obstruction, constipation symptoms, hematochezia, and also a palpable mass. Of course, don't forget your constitution symptoms, the fever, night sweats, and also being a TB, weight of loss, and anorexia. Ulceration and fistula, which resembles a Crohn's disease. So surgery is required in most of the cases, and also you can also add anti-TB drugs. So diagnosis, histology, and culture. So you realize that culture is actually a gold standard of all your TB and extrapulmonary TB also. TB peritonitis, as a result of direct spread of the bacilla from ruptured lymph nodes and intra-abdominal organs or hematogenous seeding. So it can have non-specific abdominal pain, fever, and ascites. So diagnosis, you can do your paracentesis, which reveals an exudative fluid, usually lymphocytic. So you do your normal culture and laparoscopic also is indicated for peritoneal biopsy. Miliary TB, where you have a picture of a miliary TB as a result of, so you remember it can, as I said, TB can spread hematogenously. So you can have a picture of a systemic manifestation, so but presents classically as a pyrexia of uncertain cause. So you can have a TB of the choroid tubercles on fundoscopy, that is on the eyes. You can also have a liver involvement and also spleen. So remember when you are doing your examination also, you need to check your liver and the spleen as they are the common miliary picture of involvement. Also, of course, you have a miliary lesions on the chest X-ray as an extrapulmonary pulmonary TB. So I think these are picture is a next way to appreciate the miliary picture of the TB. So you can see diffuse opacities or those picture of consolidations. I think that was my last slide. I'm sorry, I think it was a long presentation. Maybe I'll invite Prof to take us to the next part.
All right. You can hear me?
Yes, we can, Prof.
Oh, thank you. Good. So I think I want to make a few comments about some of the things that you have raised. I think this is a very extensive presentation that seems to have covered a lot of areas. Very extensive indeed. You've talked about the covering primary TB, secondary TB, pathophysiology, pathogenesis that was covered by your colleague in the fourth year. And now we came more into the issues of the TB management and investigations, which I think are also covered very well. Now, there are just a few additional comments that I will make. The first one, of course, in terms of TB diagnosis, you need to do, right now we do GeneXpert. This is the step that is currently done. And then we do sputum smears are mainly reserved for follow-up, like at month 2, you said month 5 and month 6. But if you work in a place where you can't afford to do a GeneXpert, then definitely you have to do sputum microscopy. TB cultures still remain very important. We do what is called first-line cultures, that is to your rifampicin, pyrazina, ethambutol, and isoniazid. And then you do second-line second line TB cultures will now be testing for drugs like fluoroquinolones and the aminoglycosides, okay? Then the other test that you can do, of course, you mentioned the urinary LAM, which is also a very important test, and we use it more in HIV-infected patients with low CD4 counts. It's much more sensitive in those patients. So again, we use it to diagnose TB in those cases. So mainly HIV patients, low CD4 counts, LAM is a good test. Very sensitive and very specific. Then I think there was something about early morning sputum. Yes, we need early morning sputum because what happens is when people sleep at night, they have a lot more respiratory secretions. Okay, so when they cough out in the morning, then they bring out these secretions and the yield for TB is usually high. Okay. The other test that I think you mentioned was the LYMPHATIC assay, which again looks for the mutations that confer resistance, like RPBO for rifampicin and INH mutations. So again, that LYMPHATIC assay 1. Then LPA2 now looks for mutations that confer resistance against second-line drugs, particularly fluoroquinolones and aminoglycosides, okay? Then there was something about hyponatremia, but I think you mentioned, you actually said it. The reason why people have hyponatremia is because of the syndrome of inappropriate ADH secretion. Okay, sometimes we do see this in patients with TB meningitis. We also do see hyponatremia sometimes in patients with severe pneumonia. So you don't get surprised if you see it on TB patients. The other comment that I probably want to make is regarding the issue of hepatotoxicity, okay? Now, this is a very common reaction that we see in practice, and usually, if the patient is not too sick, you could actually just hold the treatment, wait for 2 weeks, and the liver enzymes will actually clear. How you decide on whether or not to stop your treatment will depend on the levels of your liver enzymes, the transaminases. So if the levels are more than 5 times the upper limit, then you have to stop your TB medications and wait for 2 weeks. But sometimes patients are too sick, you don't want to wait. So you put them on what is called a holding regimen. Now the holding regimen, as you put correctly, you use streptomycin, isoniazid, and the ethambutol. You want to avoid the most hepatotoxic drugs. Pyrazinamide is the most toxic drug, so you want to avoid that, and also rifampicin, okay? And then, so use streptomycin, isoniazid, ethambutol, and you can add a quinolone. And the quinolones that we use here is either levofloxacin or moxifloxacin, okay? We don't use ciprofloxacin or norfloxacin. Those do not have a very, very good anti-tubercular effect. So we use more of the high generation, 4th generation quinolones like moxifloxacin, levofloxacin, or gatifloxacin, okay? Then I think there was something on the issues of TB HIV. I think you mentioned them very well. When to start hard and when not to start hard. The use of the various regimens, like if a patient is on clopidogrel, then you have to boost with ritonavir. We talked about that very well. If you're using a favirenz-based regimens and don't need to boost, you just need to continue. If you're going to use dolutegravir, then you give 1 dose in the evening. I think you mentioned that very well. Then of course, I think I'm glad you also mentioned about patients with TB meningitis. You have to hold your ARVs for at least 8 weeks, because if you give it early, then you can develop iris. And of course, if patients develop iris, then